thank you very much for this honor. I'm really having thought blocking anyway. First of all, it's a moment of great honor this day, the first annual conference of NIGF. Madam Sharda Jain for years was telling that we should make our own and none of us could. So I have to today tell you what is Madam Jain, we all know. And I was a senior resident in Lady Harding with Madam. And she has changed the face of practice in North India. She started gathering people in East Delhi and gynecologists. They every other weekend or a month, she started those meetings. And for decades, I am going into those meetings. They were very different, like you are seeing today. So I always used to feel, Madam, she has taught so many things. She's so inspiring, teacher of teacher. But see, you name a leader who is not here today from the north. So Madam, from today on, you are leader of leaders. And no personal agenda. I said, Madam, मैं प्रेसिडेंट थी एंड आई रियली रिस्पेक्ट हर सो मच. ट्रैवल तो करिए, मुझे ट्रैवल करना ही नहीं है, तो जिसको भी आना होता है वो आ जाता है. दिल्ली मैडम, आप तो कहीं जाते नहीं हो. सो नो ट्रैवलिंग, नो डिज़ायर फॉर एनी सोसाइटी पोस्ट, नो डिज़ायर फॉर एनी प्रेसिडेंटशिप, but see the output and see, we all think we are menopausal and Madam has produced this NIGF at this age. So, so,
Doctor, the person behind NIGF is Ragini Agarwal. That's it.
Ragini, another born leader, again Gurgaon's face of practice, she has changed. And I don't want to go into names because otherwise I will have to take everybody's name, but Madam Kamal Bakshi, because of whom I am here where I am, because of her conviction, her honesty in profession, I have to take a person who is deserving. I don't know what she saw in me, but Madam was, what she used to decide, she used to do. No politics, nobody can pressurize her. And I bow in front of you, Madam, that you have such a strong mind of your own and you are willing to face consequences of that strong mind. And we have learned that from you.
Solid support of NIGF. Absolutely solid.
I can't start without naming Madam Chandravati, Madam Usha, and so many seniors, my friends, Pratima, Renu. And Ragini's name rightly came up because in Gurgaon she has started. And my another Behna who is sitting behind, Sonia Malik. Madam, please. So coming to the topic on myoma management, it is a day-to-day problem and all of us see patients with myomas. So myoma is a very common problem, especially infertile patients, a lot. And how we know that the patient has myomas? They may be totally asymptomatic, but there are some symptoms like heavy menstrual bleeding, or they are infertile, or they come with pressure symptoms. So these are the common presentations. This is very important. You will agree, so many patients have myoma, but they do not have AUB. So there are so many theories. Like physical, it stretches the endometrium, it leads to hyperplasia of endometrium. There are so many molecular changes. I think this is an area for future research. Lot of research is going on. What exactly is going on amongst those hormones and those molecules which leads to, disturbances in hemostasis, and that leads to bleeding AUB in patients. So whenever I start on myoma, because this topic is very, very close to my heart, not all myomas need treatment. First of all, a patient comes to you, ultrasound shows a myoma 2, 3, 4 centimeters, it is just not into the cavity, she has no symptoms, you just have watchful expectancy with that patient. But any myoma which is rapidly growing or leading to symptoms needs to be tackled. So a big group is for medical management of myomas. So these are all the options. It is not that every patient requires hormones. Small myoma, they have some pain, bleeding. NSAIDs, tranexamic acid is a good hemostat and we all have been using. When it comes to hormones, many of us in younger patients prescribe combined oral contraceptive pills. So in this year 2023, what is the evidence and recommendation? Basically, what do these pills and progesterone which we keep prescribing to our patients of leiomyoma, they do? They lead to thinning of the endometrium. They work on endometrium. They do not work on myoma, and rather COC has some estrogen which leads to, and myoma is a hyperestrogen condition. Theoretically it should aggravate, but evidence does not say that very small doses of estrogen in OCP leads to growth of myoma, and as it leads to endometrial atrophy, many of patients, especially younger age patients, we want to give OCPs and it is a cheaper option, they do respond to. Now comes what majority of us write, progestogens. Tons of progestogens are written. They do not act on myoma, but again they act on the endometrium. Progesterone leads to endometrial atrophy, and that is how it takes care of AUBL. But now lot of evidence is coming, effect of progesterone on myoma, and these are all the studies. It increases angiogenesis, inhibits apoptosis, and these are the good evidences from literature that if you give a patient progesterone for very long, erroneous diagnosis of leiomyosarcoma and stump on histopathy occurs. High doses induce fibroid growth, so always give, if at all you are giving, minimal dose of progesterone. So by and large, maybe in future the time will come that progestogen, which is the first line therapy in cases of AUBL for myoma, which will not be there because effect of the drug progesterone on leiomyoma is not desirable. LNG-IUS, if your patient has added adenomyosis, these things go hand in hand. Myoma, endometriosis, adenomyosis, many patients are happily settled. LNG-IUS, again it acts on the endometrium and you don't have to take a daily dose. That is LNG-IUS, and especially if it is associated adenomyosis, it is good. GnRH agonist was considered the gold standard, but it's a very strong drug. You cannot give it for long. So what is the, in this date, what is the evidence? So what we do, if we are preparing a patient for surgery, if she comes with severe anemia, you have to have some time in your hand, then you give her GnRH, so it reduces volume. And before surgery, especially before hysteroscopic myomectomy, because it leads to endometrial atrophy to very severe degree and procedure becomes easier. Now we are having antagonists. I don't have any personal experience, anybody in the hall, but antagonists, wherever they are introduced and they are available in US and all, they are considered a good option, but we have to collect literature to give final recommendation. And in India also there are companies, I can see that they are. Now the topic of the time, if we say COCs and progesterone act mostly on endometrium and they do not have good effect on myoma, then what should be the good medical management of myoma with the drug? SPERM, selected progesterone receptor modulators. So these have come a big way, and me and Sadhana ji have been working together for quite some time. Actually, SPERM initial trials years, decades back were done by us at All India Institute. So we have really reasonably good experience with SPERM in management of myoma. So I'll just be sharing a few important clinical practice points. As a clinician, you just want to know what dose, how long, what are the side effects, how efficacious it is. So SPERMs are selected progesterone receptor modulators, which are very freely available in the market now. And let us see in the next few slides what is the evidence, how good or how effective they are in the management of leiomyoma. they are two of the sperm and they have little difference in their chemical structure. Ulipristal acetate came with a bang. We all started writing. It has been reintroduced. It was withdrawn all over the world because there were 3 cases of liver failure and they required liver transplant. So we thought if we are giving a drug and somebody goes into liver failure, it's really something very serious. So it was withdrawn. It has been reintroduced because the data has been checked again and again, and they thought it is the idiosyncrasy in some patients which leads to sperms have some effect on the liver, all sperms. So ulipristal acetate, again we all were writing, still we are writing 2.5 to 5 milligram per day, and they are like, mostly they are, except little differences, they are the same, ulipristal as well as mifepristone. And ulipristal, because severe idiosyncratic reaction and liver toxicity was highlighted, so it is we are very cautious in prescribing, and you have to really monitor liver function test. And these are the trials. Dr. Dones, who is a very big name in endoscopy, he did Pearl trial 1, 2, 3, 4, and he is a great proponent. So ulipristal available with so many companies, and as I said, they both are ulipristal and mifepristone. Since we have a lot of experience with mifepristone, I think I will be able to share it. So this is a pure antagonist but partial agonist. And which patients you should prescribe mifepristone in your clinical practice when you diagnose they are suffering from leiomyoma? Patients who want to avoid surgery, younger age, perimenopausal, you think you give for some time and they will go into natural menopause, and as an adjunct with surgery for diminishing size. So these are the indications. Not every myoma is to be prescribed mifepristone, but you have to select out contraindications you should see, and mifepristone is a drug which is commonly prescribed for management of leiomyoma. So the next question is, what should be the dose? And dose finding studies we did All India Institute years back, and it is realized 200, 125, 10. Now studies are coming, even 5 milligram, 2.5 is also very effective. So presently in my practice we mostly write 10 milligram, but it is we have to generate more evidence and data, and there are studies they are giving bi-weekly, they are giving vaginal route, especially for patients who don't tolerate oral. And the biggest problem is, you all will agree with me, you start a patient on either ulipristal or mifepristone, you do a follow-up ultrasound, endometrium is found very thick. So one really feels whether it is endometrial hyperplasia. We did decade back this study and gave patients mifepristone, and once she stopped it, we did their endometrial biopsy. And now there is enough literature that it is just progesterone associated edema, it is not hyperplasia, and that is the reason in literature that if you are giving a patient for 12 weeks, 14 weeks, you wait for 1 or 2 periods so that she sheds her endometrium. After her endometrium is shed, you do ultrasound, and if it becomes normal endometrial thickness, then it is a reversible action, and majority of studies has found that. So for endometrial hyperplasia, so-called hyperplasia, it is PAF effect, and fearing that it may be pre-malignant, malignant, there is no evidence, and you should wait and tell your patient, once you stop mifepristone, her next period may be heavier than the previous ones because she is shedding all that endometrium. And Dr. Dones with the ulipristal did so many studies that you let the endometrium shed, and again, because clinicians, colleagues always ask me whether how long you can continue. So that is the reason in the literature, mifepristone or ulipristal, they are given for few cycles, 12 to 16, they are given a gap so that she sheds her that thickened endometrium, and then you start again, and always monitor with liver function test. Although none of the studies ever have liver failure with mifepristone. That is the reason I personally think for the time being, till more data is generated, mifepristone in our practice is the drug of choice. But no drug is without side effects. Patients ask, Kuch, I won't have any side effect. I say, everything you take has side effect. You get married, you get a husband, you feel so happy. Over the years, you realize what are the side effects, and we all are still, So everything has side effect, and these drugs, mifepristone is no exception. Patients complain of muscle fatigue, weakness, but they are not very serious side effects, and you have to closely monitor your patient, especially with LFT. There are very nice recommendations. If LFT up to twice the normal ALT and AST, SGOT, SGPT, then you can continue, and more than twice, then you should withdraw the drug, because if anyone is having increased SGOT, SGPT, those hepatocytes are getting damaged, and liver is very, very important and precious an organ. And these are all old and new studies, Cochrane review, where mifepristone. So mifepristone will be little pseudo hyperplastic on the endometrium, but on myoma, these SERMs, mifepristone and others, they will be having reduction in some size, which is temporary. More important is these drugs lead to amenorrhea, so patients' AUB goes away, and there is no increase in the size. That is also a very big thing, and if at all, temporary size reduction is there. So again, in very reputed journals, studies are coming from time to time. Now there are a number of studies. So all published trials of mifepristone show reduction in leiomyoma size and improvement in AUB. And this is a very old study of mine, and where we made that Gacy's guidelines. At that time it was not available. I used to talk to every company person, please, you should bring in lower dose, and these people brought it, because we were breaking those tablets in our pharmacology department. 200 or 100 was available, and then giving to patients which had lot of calibration problems. So the principle that you should give a drug with minimum effective dose, so 10 milligram is a very good dose. So the advantages are it's effective, as effective in studies at GnRH, side effects are less, oral route is because GnRH is to be given injection, and especially when you want patients come with 5-6 grams of hemoglobin, you can't operate, you can put them on mifepristone, and menses revert after some time, and it improves quality of life when it is on the drug. Everybody agrees, late age patients, big myomas, hysterectomy is the answer. So this was all about AUBL. Now a big other effect of fibroid is infertility, which is really very, very dear to our heart, because lot of work, 30 to 40% of our operative work is myomectomy. So I can go on and on, but I think I will finish in my allotted time. So fibroids leading to infertility. I will just give few, and this is a very important slide. Now the literature and lot of research is telling lot more is going on in the endometrium, IL-10, glycogen level, so many things are altered, and it is the endomyometrial junction which is very important. It is the alteration in the peristalsis of the normal areas. And these IVF people are teaching us so many lessons, because they are further going into deeper waters. And fibroids may affect fertility not only by mechanical presence, but by many other ways. There are some studies that these fibroids, lead to increased prolactin, increase many substances which presently we are not measuring, because even smaller fibroids, more the fibroid is towards cavity and near junctional zone, higher are the chances that it may be a reason for infertility. So another question is when to operate. As I said, not all fibroids require surgery. You have to select out. All submucous myomas which are giving to symptoms are very good candidates for myomectomy. You do myomectomy, she conceives in 2-3 cycles. So in asymptomatic patients also, especially if they are 0, 1, 2, 3, even there is some literature, current article I was reading, 4 is to be divided into 4A and 4B, and you have to study deeply their peristaltic and their endomyometrial junctional effects if you want to go deep into learning which fibroid is leading to infertility and which will be, patient will be benefited by your myomectomy. And fibroids, anybody will get up and say, I have seen so many patients fibroid with pregnancy, and one area of our work is cesarean myomectomy. So patients come with huge myomas and pregnancy. So it is not that. In future maybe we will be able to identify which patients' fibroids are leading to infertility, because lot more patients with different size of myomas, they come with fertility. So it is not that the patient doesn't become pregnant with presence of fibroid, but number of studies have shown that the chances of implantation effect is there, and IVF colleagues sent so many patients over the years, it is increasing, remove this myoma, because they don't want to take any chance. You remove myoma and the pregnancy rates are statistically significantly better, proving that fibroids have some effect on implantation, and these are those studies. Cavity distorting myoma in any way in an infertile patient you feel like removing, because statistically significant pregnancy. So what should be the size of myoma? It started with 7 centimeter, then 4, then 3, and now many people say any size, and I will now next I'll just show you 4 or 5 video clips because I have to finish on time. So as a surgeon for myoma, especially infertility, fertility enhancing surgeon, you have to think a lot, read a lot, go with the literature. Mapping is very important. It is not that I never get my MRI done. We have removed 26, 28, colleagues are sitting here. Just in the morning somebody said you removed 26 myomas and patient conceived and delivered with me. For that you have to really go very deep into it. So I think I'll skip all this and go to some video clips, so that this slide I never remove. It's very old slide, you must have seen. Gone are the days, Sir Boni sir, we respect him a lot. He said, just give an incision, go anterior, transcavity posterior. Those times IVF was not there. I say nowadays, even if you damage somebody's tubes, endometrium should be a big, you should save endometrium, because if she develops Escherman, it's a big problem. And now even all IVF colleagues will agree, surrogacy is a big issue. So you have to respect not to damage endometrium, not to damage tubes, and remove myoma. And see, majority of time, if you learn patiently, this is the endometrium, how nicely this myoma was 2/3 in the cavity. So you can save opening endometrial cavity, and it is a very good way to avoid Escherman and synecdoche in the uterus. So as far as possible, go in the layers. The biggest secret is stay inside the capsule of myoma, respect cavity. We always put a marker in the cavity so that we are able to, understand where exactly we are going. And with increasing experience over decades, majority of time, you are able to avoid opening cavity. So see, it is not that myomectomy. It is after your myomectomy, patient should be able to conceive, carry the pregnancy to term and deliver. So that is the aim. It is not just doing a good myomectomy. And these are the secrets of success. Since these barb sutures have been introduced, it has made life simpler, because you don't need an assistant to hold your thread, and you can finish the part with a continuous suture. Otherwise your suture goes back. So with barb it stays wherever you pull, and this is the end result of a myomectomy. This is the baseball suturing. But every patient is different, as every flower has different flavor. Every patient of every myoma is different. You have to make a plan beforehand in your mind and then go for surgery the next day. This is a comparatively recent work of ours. This patient came with partly septate, partly bicornuate, and having submucous myoma. So olden days we used to do it in sittings, but with increasing experience we removed her septum from below. In the same sitting we will be removing her myoma without opening her cavity. She conceived after 3 months and delivered with us. So this patient taught me malformation. Sometimes madam will order me and I'll come. I have very large experience with congenital. See the huge ovary, AMH was not proportionately higher. So that is the problem. And this was the myoma after septum resection. And then it is not a big myoma, but it was a reason for AUB. And see, stay inside the capsule. It is not at all difficult. Only thing we have to that mind, that patience, and in a minute you will see the intact cavity, how it is protruding. And to my mind, a successful myomectomy is saving the organs, not to damage cornu, not to damage cavity, and a proper suturing. It may be 1, 2, 3, whatever layers, it should not give way when it is next pregnancy. And the secret mantra is, don't leave dead space, don't put too much of cautery, uterus will not rupture. Otherwise, suturing should be good. So this is, and these sutures make it so easy. The patient delivered, became pregnant in few months time. So this is what is myomectomy for a small myoma. Now I think I will leave all these patients. Robotics we did for years. Again, to highlight and to emphasize on to my point that myomas should be very small. Myomas may also be a reason, and this is one such patient. Sometimes it is very difficult, so you keep MRI picture in the OT, go again and again, look for the location, and I think I'll skip because I have to respect time. Broad ligament myomas, all the secrets of success, and ureter is a big issue, but I can go on and on. And anterior cervical myoma, again you have to be very careful not to damage her cervix. So please hold the cervix, both the lips with valcellum, otherwise it gets pulled and it gets removed. I'm not showing all these. Posterior myoma, again these myomas are, this is the patient which I would like to show. This is a gynecologist. I operated her few months back. Somebody did her lap myomectomy and all surgeons are good, but doing them in large numbers, we put it only in back. See, this is after myomectomy, leiomyomatosis. There were so many myomas, all the abdomen was studded. This is her pouch of Douglas. And she was a gynecologist. We did laparoscopic only. See how the blood supply, these pieces, which you morcelate during surgery. And don't blame only laparoscopy. I have done number of cases after open surgery also. So, and you have to be learning what is the correct layer to remove myoma, and that is inside the capsule of myoma. She didn't require any bowel resection. Colorectal surgeon was on guard. He must have charged his fee, but I didn't call him, because if the bowel opens, then you have to do end-to-end anastomosis. And this is quite a recent work. Tomorrow also I am doing a huge patient who had 3 times myomectomy and whole abdomen is full of these myomas. So my girl said, madam, you do laparoscopy, map them, count them, then we will open and do if at all required. So this is what a myoma pieces at the end of surgery, they go and they get stuck to omentum, bowel, from wherever those parasites can gain blood supply, and they become bigger than uterus. Tomorrow we will be doing, it is just for 12-14 weeks uterus, but the myomas I think will come out in kilos. So this is what, be in the correct layer. This is the bowel mesentery. Be in the correct layer and be patient. It takes time. So don't go for your time, and just with laparoscopy you can map them better. Otherwise with open you put a hand and you may. So this is what is leiomyomatosis. It is not to scare anybody, it is but I thought that we should know. So all those colleagues who are not using bag, so I would urge them that it just takes 10 minutes, 5 minutes extra, train yourself outside and then put them in the bag. And beauty of it is, if you are operating a case of leiomyomatosis, please check the port sites. I'll show you just now what happened here. It was such a huge on the port site. So, and they are coming more and more commonly, so we have to remove them in the bag. Even in open, we have to put a hand and see carefully. This is, somebody said, madam, it is in the bladder, the bulb. I said, no, this is a myoma. So please be careful. Bladder bulb in the bladder also looks like, and if you open, then instead of myoma, the catheter will greet you. So, and once the catheter is, it looks very catchy. Everybody from the neighboring OT comes, what is there, what is going on, where the catheter, so, and you cannot hide it. And this is the port site from where myomectomy has been done. So if you want to do a complete job, release it nicely. If I pull it premature, it will be, so you have to release it after a certain, you have released it up to a point, otherwise it will break. So a huge myomas from the port site. So if you are doing these cases open, because I don't know, I get lot many patients of leiomyomatosis, maybe the referral pattern. Tomorrow also we are doing one. So this is what. Remove all the myomas painstakingly, and once you see and do such a case, you will always be very careful with the pieces in future, because no one wants, we are not bad people, we really want nothing should happen to our patients. So, and not that we do 100%, we get 4 kgs and that kind of myoma. And I don't think you should be, nowadays what is happening, these youngsters are just being trained on laparoscopy. So they leave the patient, she is not fit for laparoscopy. I don't think it is correct. So we have to train our youngsters that they should learn opening. These are some of the ways, but putting a section. We remove myomas from a very small incision, just bikini line incisions, and we map it beforehand. This is a 4 kg myoma, you will see it comes out. And so all kind of these manipulations, and in our practice these tourniquets, different tourniquets, different ways to cut supply, because we have large amount of, fairly good amount of work on placenta accretas, which still are big nightmare. So we have learnt how to achieve hemostasis, and it really helps. So these are huge myomas. You can just with a bikini incision, otherwise you will take hours in morcellation. Removing the myoma is not the problem. Morcellating such a big myoma becomes an issue. It takes lot more time. And this is what restore. This is put a tourniquet nicely, hardly you will require blood transfusion. I can go on and temporarily cut off supply from the infundibulopelvic, and then nicely do your work, they won't bleed. So all kind of patients are there, they do bleed also, but these are the mantras to reduce blood loss. Because myomectomy for decades we have been doing, I think we have, and everybody I say that myomectomy is a very sexy surgery. So every patient is different, and you really enjoy once your patient conceives and delivers with you. So this is that 3.6 kg, I think whatever size is the myoma, and it is just with a small incision. So you map it, anterior wall myoma, you remove in bits and pieces the myoma. And then comes our another work, hysteroscopic myomectomy. Number of patients come, you enter with the scope and you feel you are in a jungle of myoma. See this patient, I think 16, 18, and she became pregnant and delivered. So don't start resecting. First you map and count where they are, what is their location. With MRI see how many are 0, 1, 2. And this is a patient where all kind of grade 0, 1, 2, all my, this is the last. So I have skipped all those. So, and then start with posterior wall. If you resect anterior wall, all the chips will be on posterior wall. So these are small practice tips which are really very helpful for the youngsters, and our teachers are sitting here who have built our basics on these procedures. So मैं उन सबको नमन करती हूँ जिन्हें देख देख के हमने लाइफ में इतना सीखा. और this is what, be inside, don't damage the endometrium. Stay after removing some myomas, do nice bimanual palpation, and then you go again, you will see whatever part is in the myometrium, it will come out. And see, don't damage the adjacent endometrium. Myoma looks very different. So you scoop it out. You scoop it out so that the endometrium doesn't get damaged. In these cases where you are kissing myoma's anterior posterior wall, we believe in removing in one sitting mostly, unless our anesthetist says that water absorption is too much. And this is what, and then put a Foley's catheter or some stenting kind of thing for some time, so that Asherman is a big issue if you are removing such multiple myomas. But respect her endometrium, just give an incision, wait for some time, do nice bimanual examination again and again, so that the part which is inside myometrium, it comes out. And this patient also became pregnant. Unfortunately, she had malformations, so she landed between IUD and it was some syndrome. So this is what is hysteroscopic myomectomy. You have to be more careful in hysteroscopic. I used to take lot of pride that I remove very big myomas hysteroscopically. I have stopped that because endometrium is to be respected. Fibroid which is more than 4 centimeters type 2, we go with laparoscopic approach. More and more threshold for lap is going. But 0 and 1, 0 whatever size you can remove. And this is the end view, so that the cavity is regular, they become 5-6 grams. So now a word about uterine. In the city of Gurgaon, some very good centers are doing. It is the biggest problem is non-communication and non-cooperation, the word I am using, between the gynecologist and radiologist. You just send a patient, they don't know how to follow, and they don't know really what should be the indication, what are the contraindications. Number of fibroids after embolization are coming with lot of pus, and they get, and submucous myoma is never for embolization. So all these things are kept to be mind. I think I have finished with my time. HIFU again some colleagues are doing. The lot advancement has to occur before taking it as a standard practice, HIFU and embolization, especially in infertile patients, because if those particles go into the infundibulopelvic and ovary, she may land up in ovarian, premature ovarian failure. So myomas, medical management had its own role, COCs, progestogens, but please be careful when you are prescribing lot of progestogens. Anti-progestogen SERMs are a reasonably good choice. GnRH has its own place. Antagonists will come in the future. And when you do myomectomy, don't think I am doing hysteroscopic, laparoscopy or open. You should be able to do a precise job for the patient so that she conceives and delivers. And it requires, I think, lot of training to do that. And removal of even small size fibroids. This our IVF colleague Sonia Ben is sitting behind, I don't know why today, and she has such good understanding of the subject. Even small cavity distorting, even FIGO 4A, there is literature now. They may be a reason for infertility. IVF stakes are so high, so remove myoma precisely, gives gap of few months and then implant. Statistically significantly better rates are achieved. Stay intracapsular, clear knowledge of anatomy, and of course training is very important. Thank you very much for your patient hearing.
Thank you.